Good evening. This is Taranjita Huja, the Director of ICE and ACE Continuity Clinic. I want to thank all of my preceptors and site directors that have joined tonight's webinar on teaching students how to think like doctors. I want to introduce my colleague, Dr. Gabrielle Goldberg, who will be really taking the lead on this webinar, and I'll give her a chance to introduce herself.
Good evening, this is Dr. Gabrielle Goldberg. I'm currently full-time faculty at the School of Medicine. My background and training is in hematology oncology, and I practiced palliative medicine before coming out to Hofstra. And now I'm involved in designing the clinical learning curriculum that we'll be speaking about today. So the goals of our webinar for this evening are to share a new aspect of the curriculum that we're working on to focus and build up our curriculum on clinical reasoning as a complement to the ICE program. We would also like to introduce this as a new teaching opportunity for preceptors in ICE who want more opportunities for teaching at the School of Medicine.
I wanted to remind the participants that you can type in questions while the webinar is going on. We will collect the questions and respond to them at the end. This webinar is also going to be recorded and archived on our website. So if any of your colleagues would like to watch it at a later time, we will be sending the link out this week. So just to give you an overview of the curriculum at the Hofstra Northwell School of Medicine. As you all may know, we are a fully integrated curriculum, so students begin with the basic science and clinical science hand in hand from the beginning of their education. The first 100 weeks really focuses on case-based learning in the Pearl setting, and they are able to integrate patients that they've seen in ICE into the classroom setting, and it becomes very valuable when students can have a link made from something they learned in the classroom and they get to see in the office, or vice versa. And then the second 100 weeks, which is basically the advanced clinical experiences, is the third and fourth year, is an inpatient, mainly inpatient experience. They do have a continuity clinic, yes, experience, which is about 6 months of their third year, and then they also have sub-internships in medicine, critical care, emergency medicine, and other disciplines. So this is the slide of our first 100 weeks courses. If you notice on the left, the curricular components weave through each course. So mechanisms of health, disease, and intervention is where our basic science lives. Structure is the anatomy, it's the embryology, histology, physical diagnosis, imaging, and patient-physician societies, all the non-biological sciences. This is where the communications lives, humanities, and these three curricular components weave through each vertical course. The courses that are circled, biological imperative, is the first year course that is currently running, and the interacting with the environment is the current second year course that's running. These courses this is when we introduce these clinical learning sessions at the medical school, and there will be opportunities for you as preceptors to participate in running these sessions in the courses that follow through. So just to catch you up on what the students have already learned, in CPR, which is the first course that they have, they get a 7-week course on physical diagnosis, and that is our Hofstra core exam. In all the subsequent courses, they actually get advanced physical diagnosis sessions based on whatever they're focusing on in the classroom. They also learn a 7-week communications course in CPR that's done in small groups, and we really focus on patient-centered communication skills, really understanding the patient's story, their chief complaint, how it's impacting them, what they think is going on with them, what their concerns are, and we have a big focus on empathy, and the 3 micro skills that we teach the students are reflection, legitimation, and exploration. We will have a follow-up webinar on December 8th at 5:30 on the communications course here at the medical school. So if any of you are interested, please join in. You will be getting a link to register this week.
In terms of our clinical reasoning curriculum, we hope that we are training our medical students to think like doctors and really develop medical and clinical reasoning based on their knowledge of science to trust their clinical instincts in order to focus their physical exams and to focus the testing that they'll do, hopefully to be conservative in their need to test and be cost-saving in their approach. So we thought this was a nice demonstration of that. All of you think like doctors, you all practice like doctors, you are doctors, and I think we learned to do clinical reasoning by role modeling and trial and error and feedback from our faculty in the clinical years. I personally didn't learn a lot of these terms, but knew how to do these things. I think it's very helpful to think about specific skills that we have all developed for ourselves and give them names so as to better teach our students how to accomplish these things and give them specific feedback on how they're doing. So just to share some of the terms that we use in clinical reasoning, illness scripts is one thing that was introduced to our second-year students during their first clinical learning session, which I'll talk about shortly. An illness script is an ideal representation of an illness that could be as short as a paragraph or as long as a book chapter, but it's the script we have in our mind of what the story sounds like for a patient with iron deficiency anemia, for example. Semantic qualifiers are those words that help us to represent a patient's problem. Often they're binary, so it may be acute versus chronic, or in some cases acute versus subacute versus chronic, that help us tell our listener when we're giving an oral presentation or a reader from a written presentation to better categorize what type of diagnoses we might be considering when they're listening to our presentation. In terms of differential diagnosis, I think this is a term that we're all familiar with. Some students have come to us having learned about the Vindicate mnemonic from their preceptors. Other mnemonics exist, such as vitamin D. What we're going to be teaching our students, at least to start, is a body system approach, which mirrors how they learn physical diagnosis, how they learn their basic science, and how we teach them the review of systems and communications. The opening statement is generally the first line of your HPI, or in a more refined way, the first line of your assessment. Can also be referred to as the problem representation. It's a sentence that includes the answers to the questions, who is this patient, what is the context, what is the problem? So for example, from our clinical learning session we did with the first year students today, we discussed a 49-year-old woman with a significant family history for malignancy presenting with a subacute complaint of fatigue associated with shortness of breath on exertion and tachycardia. We also want to help our students think about performing hypothesis-driven physical diagnoses. So understanding that they need to know how to complete a full Hofstra exam, but need to tailor that exam based on the patient's chief complaint and based on what they think most likely to be the differential diagnosis, to then use the physical exam as a means of testing their hypothesis. So the goals of the clinical learning sessions are fourfold. One is the clinical reasoning that I've spoken about to really push our students to think like physicians. Second is the hypothesis-driven physical diagnosis, which I just mentioned. Third is the oral presentation, and finally working on written presentation. And for at least the current first years and the second years who are just being exposed to this curriculum in terms of oral presentation and written presentation, we're really focusing on helping them to perfect their presentation of the HPI. So what do these sessions actually consist of? So we have small groups of approximately 11 students who meet with faculty for an hour and 50-minute sessions. Our goal is to have 3 sessions during each of the courses, which Dr. Ahuja spoke about. During the first 45 minutes of the session, we really push the students to use the communication skills they learned in CPR and be thoughtful about what is happening. So we start with the students doing their general introduction to the patient, introducing themselves, their role, using a 2-patient identifier, and eliciting a chief complaint. We then, in real time, stop as a group and generate a differential diagnosis based on the chief complaint. And really push the students to think broadly in terms of body systems. And then as we focus our history, and different students have a chance to take on the role of the physician in the history gathering to really use their hypotheses to focus their history taking. So think about a complaint of fatigue, and if anemia is on our differential, to think about which body systems we want to ask about to focus our review of systems up into the history of the present illness. So if the patient has complained about tachycardia, to make sure that we include other symptoms from the cardiac review of systems. Does the patient wake up at night short of breath? Do they have any lower extremity edema? So really be thoughtful about how they ask questions during the history. And this goes on for approximately 45 minutes. At the end, we have hopefully narrowed our large differential down to 2 or 3 most likely diagnoses, and can then discuss as a group which body systems on our physical diagnosis are going to be most helpful to further narrow down our differential, and what specific pertinent positives or negatives would we expect to find to confirm or deny each of those possibilities. The students are then given 20 minutes to practice those aspects of the physical exam on each other with feedback and mentorship from the facilitators in the room. We then have 10 minutes during which we share the actual physical findings for that patient, whether it's a heart murmur that we can play for them, an image of what the patient's rash looked like, or their actual just report of the physical exam, and then can discuss what these findings mean and how that confirms our ultimate diagnosis. The students are then given a couple of minutes to gather their thoughts, and given the opportunity, our goal is to have 3 students present each time, but have an opportunity to present to their colleagues an oral presentation practice of the chief complaint and the HPI with feedback from their peers. And then we do a wrap-up of approximately 5 minutes during which the students all identify their take-home points. This is just an illustration of the communication skills that we use during the clinical learning sessions. All of the faculty are provided with guides with a case summary, so the faculty play the patient that the students are interviewing, and we do our best to really be explicit about what is the patient's feeling of the impact of the illness, the concern, the explanatory model, and what are the empathic opportunities for that case, so the students really have a chance to use all of their communication skills. So the schedule for the current classes, the BI, which is the biologic imperative, is currently running for the first years. Those students had a 1-hour introduction to the clinical learning sessions on October 10th. They then did their first clinical learning session, which was a chief complaint of cough, which is an ultimate diagnosis of acute bronchitis. So we're trying to do as much bread and butter medicine as possible. Often in the Pearls cases, often they're esoteric diagnoses used to illustrate a basic science concept, where here we're using their basic science concepts and applying it to more common diagnoses. On November 1st, they had a clinical reasoning large group session with Dr. Smith, where he role modeled his approach to clinical reasoning, and the students then had their second small group experience with a chief complaint of fatigue this morning with an ultimate diagnosis of iron deficiency anemia, secondary to a colon cancer, and they will have their final session on November 29th. In terms of the second years for interacting with the environment, they had a clinical reasoning session on October 25th and had their first case last week of knee pain with an ultimate diagnosis of osteoarthritis, and you can see what our plan is for the remaining 2 sessions for the second years. In terms of assessment, we do have some assessment for this curriculum because we strongly believe that assessment guides learning, so as a motivating factor for our students. At the conclusion of the session, the students are expected by this following Sunday at noon to submit to Blackboard, which is an electronic submission we have for them, their write-up of the chief complaint and HPI, and after the submission time has been met, we then release a colorful, annotated, suggested version of the HPI against which they can compare their work. During the actual session, the students provide formative feedback to their peers on their oral presentation skills based on a checklist that we provide. And the faculty in the room also take notes on how the students are doing and will provide a summative assessment at the conclusion of the 3 sessions. And at the final exam, they will be evaluated on their clinical learning and clinical reasoning during their time at CLI. So I think we are happy to take questions. In addition to wanting to share this curriculum with you, we're also using this as an opportunity to look for additional faculty to join us for this curriculum. I'll tell you that the feedback we've had so far is that these sessions are a lot of fun, both for the faculty and the students. I assure you, you will be blown away by what our first year students are really able to do in terms of gathering a history and reasoning through the possible diagnoses based on the science they've learned in a really short period of time. And these sessions are really fun to do, but particularly fun if there are 2 faculty in the room. So the more faculty we can get, the better the experience is for everybody. For the upcoming courses, for the MS1s, the course entitled Fueling the Body, which includes a lot of our GI and endocrine body systems, will be starting in January. So we have 2 sessions running for them, February 14th and March 7th, and we will be running 2 faculty development sessions in January to make it easy for those who haven't participated yet to learn more about the curriculum. And the second years will be doing human condition, which is more the neurology and psychiatry content, and there will be 3 sessions, and you can see the dates here. So those of you who are interested in learning more and or participating, we welcome you to contact us, and we can get you signed up for those sessions.
So we have 2 questions that have come in. I'll read the first question. What if I want to participate but can't commit to 3 sessions?
So that's a great question. We do encourage when we send out the invites that you be available for both or all of the sessions during a given course so that you have enough information to fully be able to assess the students. That being said, having an extra faculty in the room even once is incredibly helpful. Actually had one of the basic science faculty join me this morning to play the role of the patient, which freed me as the facilitator to sit back, think about when I was going to time the student out and how to push the students to be thoughtful in their next steps in the communication interaction. So if you're interested just in observing once and helping us out playing a patient, we certainly welcome you to do that, and hopefully to then inspire you to sign up for multiple sessions in subsequent courses.
The second question that has come in is, do I have to be a content expert to participate in the session?
Also a great question. I'm trained in internal medicine, so certainly when we're going to have a pediatric case, I am looking forward to having the help of our pediatric specialists to guide me, and I will tell you that we design a pretty detailed faculty guide during which we guide you through the content for the session, give you the expected differential diagnosis chart based on body system for the chief complaint, adjusted for what we expect our students to be able to generate based on their basic science knowledge, and include specific quotes about the probability of different things and other teaching points that you can make during the session. So the guide is really there as a crutch for those of us who need it, or just a security blanket for those of us who need that, but it's quite detailed and people have found it to be useful.
Thank you, Dr. Goldberg, for joining us this evening to help run this informative webinar. I hope that the attendees were able to take away something from it, and even if you can't join us for the sessions at the school, I encourage you all to push your students to clinically reason in ICE, and I think everything that we can do together for them, they take away a lot from it. And I hope everyone has a great evening. This will be, again, posted on our website, and the link will be sent out this week. Have a good evening. Thank you.